Hey everyone, my name is Sam Astani and I'm a neurocritical care fellow here at Washington University. Today we're going to spend some time together talking about acute ischemic stroke and intracerebral hemorrhages. These are both very common conditions that you will come in contact with in the inpatient setting, so it's important for all specialties to be familiar with the management of stroke in the acute setting. By the end of this lecture, my hope is that we will all be familiar with acute management of stroke. You'll be able to identify which patient with acute ischemic stroke is at risk of developing secondary brain injury, describe the treatment of ischemic stroke with herniation, describe the workup and management of a patient with intracerebral hemorrhage. So let's get started. Stroke is a very common disease and is defined as sudden onset of neurological deficits. The first most common being ischemic stroke, and then there's hemorrhagic stroke, which is then further split into intracerebral hemorrhage and subarachnoid hemorrhage. When I think of stroke and the initial treatment of ischemic stroke, I think of it as phases of contact, and there are really three different points of contact the patient will encounter. First, the family will recognize the symptoms of either weakness on one side of the body, speech difficulties, facial drooping, or even being found down. It is important that when these symptoms are discovered, action is taken immediately by calling EMS, and this is the first point of contact. The second point of contact will be in the ED, including the ED physician, ED nurses, the neurologist, the neuroradiologist, and then depending on treatment, a neurointerventionalist may also be involved in second point of contact for decision-making on mechanical thrombectomy. The third point of contact then depends on treatment, but also depends on the neurologist's discretion of whether the patient may deteriorate. They may go to a stroke unit, which is typically a step-down unit that takes care of patients after IV thrombolytics, or may not receive thrombolytics but are not at risk of developing secondary brain injury. Or if a patient receives mechanical thrombectomy, or if the neurologist deems that this patient is at risk of developing secondary brain injury, or may even have other medical complications such as airway compromise or bleeding after IV thrombolytics, the patient then may be going to a neurological ICU. There are four different types of stroke centers as defined by the Joint Commission. There are acute stroke-ready hospitals, which can provide basic stroke triage, emergency services, but ultimately coordinate in transferring the patient to a higher level of care. There are primary stroke centers, which can provide intensive care beds and are able to give IV thrombolytics, but if the patient needs mechanical thrombectomy, they need to be transferred to another center. And then, as the name implies, there are thrombectomy-capable centers, which can perform mechanical thrombectomy. And then finally, a comprehensive stroke center. This includes physicians specialized in vascular neurology, endovascular neurosurgery, and neurosurgery. These facilities have 24/7 coverage of endovascular capabilities or OR time, as well as a dedicated ICU, such as a Neuro ICU, for these patients. Comprehensive stroke centers also have the expertise in treating intracerebral hemorrhage and subarachnoid hemorrhage as well. So at a comprehensive stroke center, when a patient arrives via EMS, they are met by an interdisciplinary team, including the ED physician, the neurologist, nurses, and a pharmacist. The team gathers important history from either the patient, if you're able, the family, or EMS, while nurses perform critical work such as obtaining IV access, acquiring the EKG, and obtaining labs including a CBC, a basic metabolic panel, glucose, and a coagulation panel. During the initial encounter, it is imperative that a focus history and an essential neurological exam called the NIH stroke scale be obtained in a concise and effective manner. There are several important key factors that are important to obtain from the history. First, if there was a witness, find out what happened. There are many mimics of stroke, including seizures, migraines, reactivation of old lesions, or toxic metabolic insults. The time of onset and the time of the last known normal and a past medical history is crucial as well. Treatment of acute stroke is determined by time windows. If the last known normal is before 4.5 hours, the patient may be evaluated for IV thrombolytics with either alteplase or tenecteplase. After obtaining the history, a CT head must be obtained to rule out intracerebral hemorrhage, and a list of criteria with absolute and relative contraindications should be reviewed in order to give IV thrombolytics. This list may include use of anticoagulants, recent surgeries, prior intracerebral hemorrhages or traumas, just to name a few. And if able to receive IV thrombolytics, the blood pressure should be carefully lowered to less than 185/110. Of note, alteplase is dosed as a bolus and an infusion, and then tenecteplase, which is new, is given as a bolus. There's also a recent study published that showed patients who woke up with stroke symptoms may still benefit from IV thrombolytics. This is done via a rapid sequence MRI, which you compare to two different sets of images. And if there is a mismatch, then these patients are still eligible for IV thrombolytics, but we won't go into detail about that. So let's say you've decided whether or not to give IV thrombolytics, or the patient has arrived outside of the time window. There's still more work to be done. At this point, a CT angiogram should be performed, and if they are before 6 hours, they're still eligible for mechanical thrombectomy. These patients may have a distal internal carotid artery occlusion or a proximal MCA occlusion. If they arrive after 6 hours, a CT perfusion should be done after an angiogram. A CT perfusion quantifies blood flow through the brain using a series of CT scans with contrast and creates maps that can estimate blood flow, volume, and time it takes to reach the area of interest. A calculation is used to determine the penumbra, or the difference between ischemic tissue and already infarcted tissue, otherwise known as the core. And if meeting criteria, these patients are eligible for the procedure. So patients with stroke have better outcomes when they're going to a stroke unit. These units have trained nurses that are able to take care of acute stroke patients. Generally, post-IV thrombolytic care requires frequent neurological examinations to assess for changes that may be caused by intracerebral hemorrhage following the administration. And then if patients need fluid resuscitation, they should be given isotonic saline, not hypotonic saline, including LR. You should also avoid hypoglycemia, as it can mimic stroke-like symptoms and cause focal neurological deficits. A bedside swallowing assessment should be done by the practitioner or the nurse if they're trained. And if the patient is dysarthric or has facial weakness or has failed the bedside swallow, a speech evaluation should be pursued by a speech therapist. The blood pressure should be maintained at or below 180/105, and IV drips such as nicardipine or clofidipine can be used. And patients should not receive antithrombotics, aspirin or DVT prophylaxis, for at least 24 hours. You should also try to avoid placing devices in the patient, such as intra-arterial catheters, indwelling bladder catheters, or NG tubes, unless it's needed emergently. And then finally, after 24 hours, a CT head or MRI brain without contrast can be performed to safely administer antithrombotic agents like aspirin. Complications after mechanical thrombectomy can occur due to reperfusion injury. This can occur after opening an artery in which there is now sudden rush of blood flow in an infarcted area, and this can lead to development of cerebral edema. This would manifest as an exam change, and prompt evaluation with a CT head should be obtained, and the neurointerventionalist should be notified immediately. But if the thrombectomy is successful, blood pressure should also be controlled, and your goal should be less than or at 175/105. And additionally, neurovascular checks should be performed by you or the bedside nurse, as hematomas can occur after sheath removal. If the femoral artery is accessed and closed, a patient can develop hematoma around the site of insertion. And if a hematoma does occur, a CT of the abdomen and pelvis with contrast should be obtained to identify signs of retroperitoneal bleeding. So the primary job of the neurologist when evaluating a patient with ischemic stroke is to find out why the stroke happened in the first place, and this will guide you in secondary prevention treatment. I like to think of stroke happening in two different pathways: a platelet pathway, which we can now call Velcro, or a coagulation pathway, which I liken to Jello. Platelets in essence act like Velcro, meaning that when an artery is damaged or when there's plaque in the artery, the platelets begin to adhere to it just like a piece of Velcro would. These can cause local thrombosis, or it can embolize and travel to the brain. But blood can also clot like Jello. You can imagine when you constantly stir Jello, it stays in a liquid state. However, when you let it sit still, it becomes a solid, or Jello. Blood is very similar to this. When there's turbulent flow, it's seen in cases like atrial fibrillation, the blood starts to form clots via the coagulation cascade and can embolize to the brain. And there's a set of criteria called the TOAST criteria, which describes the different etiologies of ischemic stroke that can help you manage with secondary prevention. The first being large artery atherosclerosis. This is a platelet issue which can be seen in patients with vascular risk factors such as hypertension, smoking, or high cholesterol and diabetes, among others. The large arteries that feed the brain, or the aorta, carotid arteries, have plaque and can cause thrombosis and can embolize. There can also be intracranial vascular disease seen in large arteries as well. Strokes can come from the heart, known as cardioemboli, in patients with arrhythmias such as atrial fibrillation, endocarditis. Cardiac tumors or even congestive heart failure can lead to clots being embolized to the brain. They can develop clots from the arteries that are not due to atherosclerosis, known as non-atherosclerotic vasculopathies. These patients may have experienced trauma, like neck whiplash, or even popping of your neck, and could cause a dissection of the vertebral or carotid arteries. This is when a tear happens into the intimal wall of the artery and can cause clots to form. Non-atherosclerotic vasculopathies may also include underlying vascular disease such as vasculitis, moyamoya disease, sickle cell arteriopathy, or fibromuscular dysplasia. There's small artery disease, which is due to a patient with chronic hypertension, smoking, or diabetes. This is due to repetitive damage from decades-long disease that can cause infarctions that may be small but can have a significant impact on the patient's life. These infarctions are subcortical or can be located in the brainstem. There are hypercoagulable states that can happen in younger patients that present with stroke. It is due to conditions that cause blood to clot more than normal and is sometimes associated with a second hit, such as an illness or dehydration. And there are cryptogenic strokes that are found in patients where the etiology cannot be found. The patient should initially receive a CT scan of the head, which happened in the ED, and also receive a CT angiogram of the head and neck to evaluate the extracranial and intracranial vasculature. An EKG should be performed to see if the patient has evidence of arrhythmias. A transthoracic echocardiogram should be performed to evaluate the ejection fraction or wall motion abnormalities, valvular structures, the atrial size or the left ventricular wall size, or any evidence of intracardiac thrombus. And while these are being performed, a lipid panel, A1C, and an RPR should be performed. And if the workup remains negative, further studies such as a transesophageal echocardiogram can be done, or cardiac monitoring such as a loop recorder should be pursued, as arrhythmias can hide and show up randomly. Patients should be administered aspirin on arrival if there are no contraindications or 24 hours after administration after IV thrombolytics while the etiological evaluation is undergoing. If it is deemed that the patient has large artery intracranial atherosclerosis, studies have shown that aspirin plus a second agent, such as clopidogrel, can be started for 90 days, followed by monotherapy with aspirin. Or if the patient has minor stroke symptoms, as defined by an NIH stroke scale score less than 5, data has shown that these patients benefit from dual antiplatelet therapy for 21 days, followed by aspirin monotherapy. Patients who are found to have extracranial ICA stenosis, internal carotid artery stenosis, aspirin may be started. However, the patient should be evaluated for reperfusion procedures such as an ICA stent or carotid endarterectomy. Patients that are found to have cardioembolism or hypercoagulable states require anticoagulation, and these can be either in the form of warfarin, DOACs such as apixaban or rivaroxaban, or low molecular weight heparin. The treatment is also dependent on what type of arrhythmia is found, such as valvular atrial fibrillation or non-valvular, which type of hypercoagulable state, such as factor V Leiden or antiphospholipid syndrome, and then timing of anticoagulation is complex. There's no consensus on when to start or resume anticoagulation, and the largest risk factor is based on the size of the infarct. If the infarction is minor and uncomplicated, anticoagulation can be started after 48 hours, depending on the patient factors. If it is a large infarction, aspirin should be started, and then about 1 to 2 weeks they should be evaluated and switched to anticoagulation. Dissection is either treated with antiplatelet agents or anticoagulation, and there is no difference in the efficacy between the two treatments. Cryptogenic strokes, as we discussed, is when there's no etiological source. These patients should be treated with lifestyle modification and antiplatelet agents, and it is advised that long-term cardiac monitoring, such as a loop recorder device, is used to identify arrhythmias, and this would change management. So now that we've talked about the initial management and the care of ischemic stroke, and we've talked about the etiological workup and the secondary prevention, let's now discuss patients that are at risk of developing malignant edema leading to secondary brain injury. But before there, let's review the Monroe-Kelly doctrine in cerebral edema. The Monroe-Kelly doctrine is reviewed in detail in our TBI lecture, but it's important to remember that the brain is encompassed in a fixed structure as defined by the skull. And within the skull, there are 3 components: brain, CSF or water, and blood. And an increase in volume of one compartment is going to be accompanied by a decrease in the other structures, or intracranial pressures will rise inevitably. And in stroke specifically, what we worry about is cerebral edema increasing in volume. But first, there are two types of edema when we talk about the brain. The first being cytotoxic edema, which can be seen in cellular death. So conditions like ischemic stroke, hemorrhages, or abscesses, for example. It is due to loss of cellular integrity. This causes an accumulation of water and swelling of the cellular elements following cell death. The second type of edema we can see in brain patients is vasogenic edema, which is caused by the breakdown of the endothelial layer in the blood-brain barrier, and then allows water to travel across the endothelium, leading to extracellular fluid. This is going to be seen in patients with white matter diseases, tumors, or anything that really can cause breakdown of the blood-brain barrier. So you can see the difference in these two images. Vasogenic edema is usually finger-like projections in the white matter, whereas cytotoxic edema extends from the subcortex and can go all the way through the gray matter. So then what you should be asking yourself is, the stroke volume will be so large to cause significant swelling for which other structures of the brain are now at risk of compression and herniation. But before we go there, let's review herniation syndromes. Herniation is displacement of brain structures onto other structures. And in stroke, what can happen is an increase of cytotoxic edema leading to displacement of the brain. And there are four common types of herniation syndromes: subfalcine herniation, uncal herniation, central herniation, and tonsillar herniation. Subfalcine herniation is usually caused by a lesion in one side of the hemisphere, causing medial displacement of the hemisphere across the falx. This can cause leg weakness on the other side of the body. So let's say, for example, you had a right-sided lesion. This is now causing compression on the left side due to subfalcine herniation, and now you have right and left leg weakness. And since you have a lesion on both sides of the brain, the right and the left, consciousness may also be affected. Uncal herniation is also a lesion on one side of the cerebral hemispheres, causing unilateral movement of the medial temporal lobe, or the uncus, to be displaced and compress the midbrain. These patients will develop mental status changes such as drowsiness and eventually a coma. They will have a sluggish pupil as an early sign, followed by a fixed and dilated pupil, and then eventually a cranial nerve 3 palsy. Weakness of the ipsilateral side is also accompanied due to compression. Central herniation is a diffuse cerebral edema process, or hydrocephalus, and can cause bilateral decorticate posturing and will eventually progress to decerebrate posturing. And then there's tonsillar herniation, which is caused by infratentorial lesions. This causes the tonsils of the cerebellum to invade the foramen magnum and cause a compression along the cervical medullary junction. This can lead to hydrocephalus, cranial nerve palsies, quadriparesis, and coma due to brainstem compression. So to recap, cytotoxic edema is associated with ischemic strokes. Because of the Monroe-Kelly doctrine, an increase of one of the compartments, in this case edema, can lead to brain compression and herniation. But what patients are at risk for herniation? This goes back to our second point of contact when you're initially in the ED evaluating whether this patient needs to go to the Neuro ICU or the step-down unit. Are they going to incur enough cerebral edema to lead to brain compression and herniation? What to look out for when you're evaluating these patients? These patients at most risk of developing mass effect from cerebral edema are young. You can imagine the brain is already full, there's little to no atrophy, and so therefore there's no space for edema to form and swell. Patients that you believe are developing an ischemic stroke from an MCA territory that may be greater than 50% of the territory, or patients with posterior circulation infarctions, such as in the cerebellum. And patients with a high NIH-SS score can be used as an independent risk factor, as a high NIH score is a direct reflection of the degree of injury. And it's important to note the physical exam findings, which can be forced gaze deviation, visual field deficits, cortical signs such as aphasia or neglect, and depressed consciousness. All of these point to an exam of a large infarction and can lead to development of cerebral edema needing intervention. But what do you do with this patient? Say they're a 50-year-old with a right MCA territory infarction. He has neglect and weak on the left side. He's admitted to the ICU, and after 2 days, the nurse calls you and says the patient is becoming progressively drowsier and the exam is worsening. What do you do now that they're getting worse? It is important to keep your differential in your head as you're working them up. Increased edema with mass effect is high on the differential. However, you should also be thinking of infections such as a UTI or pneumonias, among others. Seizures, are they hypo or hyperglycemic? Or do they have any other metabolic derangements that may cause encephalopathy? Obtain an emergent CT head. This will help you confirm your working diagnosis that the patient may be herniating from cerebral edema. If the CT head is consistent with worsening midline shift, herniation, or worsening cerebral edema, consult neurosurgery immediately. The patient should be evaluated for a decompressive hemicraniectomy. There are 3 landmark trials, the Destiny, Decimal, and Hamlet trials, that show that if decompression is done early in patients less than 60 years old, this will lead to favorable outcomes and save the patient's life. General criteria include young age, less than 60, and deficits suggestive of MCA territory infarction greater than 50%. Surgical decompression in the form of a hemicraniectomy should be done before herniation has taken place for the best clinical outcome, and it is imperative that you notify neurosurgery early in this patient's hospital course. Therefore, the timing from symptom onset to decompression should be less than 48 hours. While you await recommendations from the neurosurgeon, it is time to temporize this patient medically to bridge them to surgery. Intubation should be performed for patients with diminished level of consciousness and neurological deterioration for airway protection, and you should begin hyperventilation aiming for a PCO2 of 30 to 35 millimeters of mercury. This should only be done for a short time as a bridge to a more definitive therapy, as prolonged hyperventilation can cause brain ischemia from vasoconstriction. Obviously, this is the opposite of what we want when the patient is already infarcting. Give mannitol if the patient has good renal function, or hypertonic saline. With the mannitol, the dose should be 1 gram per kg given with filtered IV tubing. If giving hypertonic saline, which can be 5%, the dose is 3.2 milliliters per kg and can be given peripherally, or 23.4%, which should be given through its central line. Either of these can be scheduled. If using mannitol, it's important to obtain a serum osmolarity and calculate the osmolar gap for your next dose. If using hypertonic saline, basic metabolic panels should be obtained to monitor the rise of sodium, as you want to be careful not to increase the sodium greater than 160, as this is an independent marker of mortality. So let's review this CT head. The way I would describe it, this is a CT head non-contrast axial view. To orient you, this is going to be the right side. This is going to be the left side. This is going to be the front of the patient's face. And down here is going to be the back. This white structure here, we describe CT in terms of density, and this white structure here is what we call as hyperdense. This is going to be skull, so anything that's more dense is going to be bright white. The structure here on the left is normal brain tissue. This is what we describe as hypodense or isodense. And this structure here on the right side is hypodense. And what we're seeing here is a cerebral infarction on the right side of the brain. This is encompassing the whole territory of the MCA. This is also encompassing the territory of the PCA. And you can see here, the ACA territory is actually spared. And we're now starting to see some midline shift occurring. So now this side of the brain is going this way. We see that the deep gray structures, the basal ganglia and the thalamus, are now also affected. This patient is going to be weak on the left side of the body. They're going to have sensory deficits on the left side. They're going to have a hemifield visual loss on the left side, and they're going to have force gaze deviation to the right. This is the type of patient that should be monitored closely in the Neuro ICU, and the type of patient that is at very deep risk of herniating clinically and radiographically. So now let's look at this CT head. This again is a non-contrasted axial cut of the head, but now we're looking at the cerebellum and the temporal lobe or the posterior fossa. Again, to reorient you, this is the right side, this is the left side, this is the front of the face, and this is the back. These structures right here are the temporal lobes, and you can see that there's already significant atrophy in this temporal lobe. And this structure here in the back, here and here, is the cerebellum. In the cerebellum, we can already see that there is hypodensity on both sides of the cerebellum, so especially within here, this structure here, and this structure here. This hypodensity is concerning for an infarction in the bilateral cerebellum. There's already effacement of the fourth ventricle. You can see that the temporal horns of the lateral ventricles are increased in size. This could be due to atrophy, but it also could be due to hydrocephalus. And there's already compression along the brainstem. Let's say you've initially admitted a patient with bilateral ataxia, nausea, headache. You've admitted him to the Neuro ICU, and your nurse is now telling you this patient is getting drowsier, and they have gaze restriction both to the right and left side laterally. So what do? You're worried that they may be clinically herniating, and you would obtain an urgent head CT and neurosurgical evaluation immediately. This patient may have obstructive hydrocephalus that may warrant an EVD, or they may need surgery. And there's 6 important points to recognize for surgery. The first being lethargy or depressed consciousness. And these are in no particular order. The second being, are they in a coma? The third being quadriparesis. This can occur due to the compression of the medullary pyramids. The fourth being ataxic respirations. You can have lateral gaze palsy, as we described in this patient. This occurs due to cranial nerve 6 being trapped due to the increased pressures, and the 6th being hydrocephalus. And while these patients are being evaluated for surgery, just like what we did with our last patient, they should be temporized medically. This would include hyperventilation, intubation if their airway needs to be protected, as well as osmotic therapy with mannitol or hypertonic saline. And these should be temporizing measures until this patient goes to surgery. So let's shift our focus now to spontaneous intracerebral hemorrhages. So I like to think of intracerebral hemorrhage also in terms of etiology, as this will help guide your management but also help you work up the patient in order to prevent it again. And there are specific conditions which can cause hemorrhages to happen. The conditions being one of the most common, which would be a hypertensive hemorrhage. These are located in the deep nuclei. So for example, the basal ganglia, the thalamus. And both of these are done due to penetrator arteries off of the MCA and PCA respectively. Next would be the cerebellum, which is due to penetrator arteries as well. Off the major cerebellar arteries. And then the pons, which, again, penetrator arteries off the basilar. Hypertensive hemorrhages have the same risk factors as we would see with lacunar or small artery disease and ischemic strokes. It's due to chronic disease and battering of these small vessels, which then have damage over time and then can burst and cause hemorrhage. Hypertensive hemorrhages can be small, meaning small symptoms like we can see in this patient right here, where there's a left thalamic hemorrhage. This patient may have sensory deficits on the right side, or hemorrhages can be catastrophic, as we can see with this image right here, where the ventricle is located close to the hemorrhage and it can cause intraventricular extension. And this can lead to hydrocephalus and significant symptoms, or even this hemorrhage right here, as we can see in the cerebellum, where there's now again, obstructive hydrocephalus from the IVH, an extensive hemorrhage within the cerebellum leading to further edema and mass effect. There are other etiologies of the hemorrhage as well. These etiologies can include cerebral amyloid angiopathy, and by history, these are usually older and in patients with history of dementia and cognitive impairment. And if you have the benefit of an old MRI, they may have microbleeds located throughout their brain. These hemorrhages can be lobar, they can be subcortical. What you can also look out for is vascular malformations. These can be in the form of AVMs, aneurysms, they can be cavernous malformations, among others. These are typically lobar hemorrhages, and they can also lead to subarachnoid hemorrhages, or they can lead to intraventricular hemorrhage. Another one to look out for and be on the radar should be cerebral venous thrombosis. We won't go into detail about CVT, but it's an important cause of hemorrhage as your treatment is totally and radically different. Other etiologies may be moya. This is typically due to proximal artery narrowing, which can lead to collateral artery formation around the circle of Willis, leading to weakened vessels that can rupture. Other causes could be RCVS or reversible cerebral vasoconstriction syndrome. These are seen in migraineurs or people that take SSRIs and can present with a thunderclap headache and can have a cortical hemorrhage. And then infections. Most importantly, HSV, which can cause hemorrhage along the medial temporal lobes. And of course, you should always remember tumors. These are characterized by circular hemorrhages. They may be on the vascular border zones and the surrounding edema. Specific tumors to be on the lookout for may include melanomas, choriocarcinomas, lung, thyroid, and renal cell tumors. Patients are injured from hemorrhages due to the sudden rush of blood flow and its mass effect on adjacent tissues. Blood volume and edema can lead to reduced perfusion and can cause local ischemia. Large hemorrhages can create such extensive mass effect from the blood volume and edema itself, in which it can now lead to herniation. Let's remember our Monroe-Kelly doctrine: brain, CSF, and blood. And as alluded to in the previous slides, hemorrhages can also occur in the ventricles, which then can lead to obstructive hydrocephalus. Patients with ICH should be triaged and transported to a stroke center with ICU capabilities. There, a focus history should be obtained promptly, as this is going to help you with etiological evaluation of the hemorrhage. Symptoms such as thunderclap headache or seizures or depressed consciousness can help you guide your workup. There are vascular risk factors: hypertension, hyperlipidemia, diabetes. Maybe they had previous imaging that showed microbleeds and a history of cognitive impairment. Smoking or antithrombotic use, such as anticoagulants, or a history of liver failure will help as well. A complete blood count, a CMP coagulation panel, cardiac workup including an EKG and troponin, a drug screen, and a pregnancy test should also be obtained in the acute setting. And finally, a CT angiogram should be performed to assess for any vascular abnormalities as part of the etiological evaluation, especially in patients that have lobar hemorrhages that are less than the age of 70, or patients that are younger than 45 with subcortical or posterior fossa hemorrhages, or patients with no history of hypertension and are younger than 70. An ICH score is then calculated on the initial arrival by the practitioner. It's a helpful tool to guide you in prognostication as you're talking with the family, as it approximates a 30-day mortality. Factors that go into the score are GCS, ICH volume, if there's IVH or not, if it's infratentorial in origin, and the age. And as you can see, it gives you a 30-day mortality. ICH score with 1, it has a mortality of 13%, and unfortunately a score of 5 is a mortality of 100%. And patients that present with ICH are usually in a hypertensive emergency, and so the treatment should be established early to help, and that treatment would be lowering blood pressure. It's a debated topic as to what to lower the blood pressure to, but now there are new recent guidelines from the 2022 American Heart Association. They use 2 major trials to help us, the INTERACT-2 and the ATTACK-2 trial. They suggest that early lowering of blood pressure, early which is 2 hours, is associated with lower risk of hemorrhage expansion, but also better than 90-day outcomes. Careful titration using IV drips will also help create a smooth, continuous lowering of blood pressure and will help sustain away from large variabilities. Patients with mild or moderate ICH and a systolic pressure from 150 to 220, lowering the blood pressure to a systolic of 140 is safe. Anything lower than that was not associated with better outcomes, but in fact had serious adverse reactions and renal disease, and therefore it's not recommended. And the patients that have a systolic blood pressure greater than 220, it's important that the blood pressure be rapidly lower, less than 220, but then reduced over a period of hours to a range of 140 to 160. The choice of medication is usually predicated upon fast titration and predictability. So therefore, IV nicardipine or clofidipine are excellent choices. If those are not available, you can use labetalol or esmolol. And we would recommend against the use of nitroprusside or nitroglycerin, as this can lead to increased intracranial pressures. And a major part of the history is seeing whether or not the patient is taking anticoagulation. If they're on anticoagulation, it's crucial that these patients receive the proper reversal agents, because if not, this can lead to hemorrhage expansion. And I would recommend that you discuss it with your pharmacist when you're making the decision on which reversal agents to use in the dose. If they're taking warfarin, they should receive prothrombin concentrate complex, or PCC for short. And if that is not available, they can receive fresh frozen plasma. But for both choices, they should receive vitamin K, as both PCC and FFP may be short-acting. If they're taking novel anticoagulants such as apixaban or rivaroxaban, the reversal agents should include andexanet alpha or PCC. Remember that if you're using andexanet alpha, the dose is dependent on which medication and what time the medication was last taken. Protamine sulfate should be used in patients that are taking heparin or low molecular weight heparin, and again, the dose is dependent on which one and how long it's been since they last taken that drug. If you've given IV TPA for a patient with acute ischemic stroke and they've now developed a hemorrhage, reversal includes cryoprecipitate. And patients that are taking antiplatelet agents such as aspirin, they should not be transfused with platelets. Large volume ICH can produce the risk of developing significant edema and therefore can cause brain compression. The compression can come from several different factors, however, the hematoma itself, rebleeding, or cerebral edema as we've discussed, or even hydrocephalus. And it's important to recognize the development of hydrocephalus clinically. These patients will become drowsier, they will develop a headache along with nausea or vomiting, they can develop urinary incontinence, and they can have upgaze restriction on oculomotor testing. And if they have hydrocephalus, an EVD should be placed. This gives you the benefit of both CSF diversion, but also helps you manage the ICP directly. Additionally, patients should have their head of bed elevated more than 30 degrees to allow for good blood flow away from the head. The head and neck should be midline. The neck should not be compressed, especially if they arrive with a C collar. That should be cleared as soon as possible. And if you're resuscitating the patient with IV fluids, it's important that you avoid using hypotonic fluids, including LR. And normal saline should be the first choice. Hypotonic fluids can lower the sodium and cause edema. And if the patient starts exhibiting neurological decline due to the mass effect from the hemorrhage or cerebral edema, a CT head should be obtained emergently. Neurosurgery consultation should be done if it's not already completed. If an EVD is in place and the ICP is elevated, CPP optimization should be completed with sedation. And if you're failing, or if the patient has signs of herniation clinically or radiographically, the patient should receive osmotic therapy, as we've discussed before, and they should be evaluated for a craniotomy or a craniectomy urgently. Neurosurgical evaluation should be warranted with any patient with acute hemorrhage that is causing rapid changes in the neurological exam or drowsiness. Factors that favor surgical removal of the clot include lesions with mass effect, cerebral edema, or midline shift to avoid herniation. If the symptoms are secondary to increased pressures or brain compression from the surrounding edema or clot. If you have an EVD in place and there's persistent ICP elevation despite maximal medical therapy. Or deterioration of the neurological status, especially in cases with brainstem compression. And of course, young patients with favorable location of evacuation, such as a lobar hemorrhage, cerebellar hemorrhage, or hemorrhage in the non-dominant hemisphere. Special consideration should be placed for patients with cerebellar hemorrhages given the close space of the posterior fossa. These patients may develop rapid hydrocephalus due to compression of the fourth ventricle. They may develop mental status changes due to compression of the brainstem. Patients with brainstem compression or a large diameter hemorrhage greater than 3 centimeters should require urgent neurosurgical decompression. And these patients, a craniectomy is likely to be performed, as this would remove the skull base and allow for adequate swelling to occur. Hemorrhages in the deep gray nuclei, such as the thalamus or the basal ganglia, it's noted that surgery is no better than medical management. So in summary, it's important to recognize the signs and symptoms of stroke early. It's important to recognize secondary brain injury. It's important to recognize impending herniation from edema. These patients should get a rapid head CT, and neurosurgery and your interdisciplinary team should all be involved. With these treatments, you're going to save a lot of lives. Thank you for listening today.